months because I just moved to a new clinic. That's why I only have 6 months follow-up. I just moved to a new clinic this year May. Okay. Another case, a salesperson, same thing, discomfort and sensitivity. And patient have full blood control, generalized gingivitis. Dare not brush these 2 teeth because very mobile and yeah, they are afraid to brush. Okay, mobility grade 2, there was median dystema, and there is over contour or restoration. And patient claimed that she couldn't recall whether she had the restoration, but it looks like a restoration here. So you look, there is a frenum pool here, and there was RT2. What I did, FGG. FGG is simple on a very bad day, right? So just slap it with FGG and I cover with Copac. And by day 3 it looks good. You can see when you see red tissue, pinkish, then it's the graft survive. So as it's over the weeks, it should get thicker and healthier and more pinkish. So this area patient did not brush, and we try to remove the over contour. That's why it resulted some roughness that area, and that's why you can see some plaque and calculus there. And our plan in long term is when patients started to brushing well, then we can plan for to close the median dystema. So what do you think of the soft tissue here? Is it improved aesthetic? For patient, if patient can clean better as it's not that tight anymore. Yeah, we have to keep on reassure patient you need to brush. Just brush as it is, and then I always introduce single tufted brush for my patient. Okay. Next one is a dentist. He had this recession due to after orthodontic treatment, and he also had a FGG done by a friend, and it failed. And after that, referred to me to manage this problem because for me, I was also afraid of doing the redo case. So again, I also reattempted FGG. This is the scarring tissue due to the FGG along the mucogingival junction. So this case RT1. Okay, I get I harvested a wider and wider and longer so that I can have better blood supply to the graft. So by 1 week, yeah, I feel very relieved when you see the tissue is red pink color. So this is what I achieved. Complete root coverage. This is the side view. And by 1 week it healed. I used a periacryl dressing to cover the area for blood stabilization, and this is by 3 weeks it healed quite well. This is the before and after. So well, I achieved complete root coverage by 1 stage 3 gingival graft. And what do you think of aesthetic? Is it acceptable to you? Yeah, patient same, never complain. Okay, and sensitivity reduced after the treatment. Okay. Another patient came for dental implant therapy. Same thing, sensitivity, discomfort when brushing the lower left region. And at baseline, actually, patient presented gingival inflammation, but I didn't capture the photo. This one is after scaling, right? And now reinforced oral hygiene. So what is non-callous cervical lesion that I mentioned earlier? Patient D33 and 34 had NCCL type 3, and you can see there's a frenum pool and shallow vestibule. So what did I do? Again, FGG. This, why? Because I find it's predictable and simple to do. So this is how I prepare my recipient site at the CEJ level. So this is where I plan to patch the FGG there. So this is, and then that time I only want to treat the 3-4. The 3-3, because patient didn't complain any sensitivity, I just want to treat the area of concern. Okay, I use Coloplast, the absorbable collagen wound dressing for this case to achieve hemostasis and wound healing, better wound healing. So by 1 week, yeah, only at the apical part it looked like there are slough and some necrotic tissue. Okay, by 2 weeks I feel relief. Okay, 3 weeks, because this area actually the enamel defect region, actually I attempted filling before I grafted, but the filling dislodged. Actually, it's for NCCR lesion, the area is reduced for resin tag infiltration, so that's why it's not really able to stick well. So this is this is a post-op by 7 weeks. So can you see this is 18 months. You can see that the creeping attachment move to the foretree and cover the recession on the foretree. Yeah. So the good thing about FGG is a creeping attachment, and patient never complain of the bulk of the soft tissue. Yeah. Only that as long as patient can keep clean and there's no phenotype pool, and you feel very sure this FGG will last forever, right? Having this big bulk of tissue. Okay. So for me, FGG, just one procedure, it can correct so many problems, and it's you feel relief, it will be stable forever. Okay, back to the choice of surgical technique. There are various surgical techniques, and there are many beautiful cases shared on social media. So the earliest technique of root coverage is FGG, and then now the trend is tunneling, restyle with CTG, right? And other factors for root coverage procedure that introduced were enamel matrix derivative, flat ridge fibrine, and soft tissue substitute can be ADM, acellular dermal matrix, or collagen matrix. So for flap and tunnel, we go for tunnel is mainly for aesthetic and to reduce morbidity of the patient. But flap also very good, can yield a very good result when it comes to root coverage. So, but for tunneling, we need a special instrument, the instrument that is bend or bendable surgical blade to perform the technique. For flap or any FGG, we just need a normal surgical blade that we can perform the surgery, right? So there are many surgical techniques. How do we select? 3 main factors I always consider. Try to look for a technique that is minimally invasive. Predictability means it's simple and definitely will achieve the successful result. And for long-term stability, meaning that we can avoid doing another surgery to achieve the same result. There is an article review on 105 or randomized controlled trial to assess which gingival phenotype modification therapy to increase the periodontal phenotype, and is there any good impact on the phenotype changes in promoting periodontal health. Okay, they found that for root coverage, CTG is always superior than others. And for non-root coverage, the FGG is always superior than AD substitute. Okay, and they found that those sites that is grafted is definitely better with reduced plaque score than the flap alone. Okay, so with grafted site can improve the local factor. But definitely autogenous graft is better than the soft tissue substitute based on the evidence. Now we move on to another case. This lady was a lawyer. She complained of recession and mobile teeth after debone orthodontic treatment. And patient came to me. That time the teeth were mobile 1 to 2 with composite resin spring on the lingual. Patient did not brush. That's why there's a lot of calculus at the interdental area. And back then, colleague performed the phenotomy for this patient, and then following that, I attended to the patient and I said, this one is you see it's not really help with the phenotomy. So again, I did a visual graph for the patient, RT2. So, these are the 4 factors that if you want to achieve root coverage with FGG, make sure you have you emulate all the muscle attachment, root surface preparation, make sure the surface is hard and clean, then the graft will cover the root. So by week 1, I feel relief, but still at week 2, I felt more relief and see more healthy tissue. So this is week 2. Okay, 1 year, 3 years. So the key to success for root coverage using free GR graft is thorough scaling and root planning, adequate relief of the flap, adequate graft covers the length and the thickness, and close contact of the graft to the recipient site. Okay. Always the suturing part is the critical part to make sure the graft is immobilized. I spend more time in suturing than harvesting. So the same patient also complained of sensitivity of upper right premolar and first molar. Okay, and there was a finger pool on the 1.5. Okay, what I did, because it's an aesthetic region, of course I harvested CTG. Okay, and for this area I prepare full split full and tunnel, because at the back, so tunnel is easier when come to suturing. So full is when there's a root surface, and split is when you want to anchor the flap. So you need to have split thickness there. So this is when come to papilla, because you want to anchor the graft and the flap, you need to epithelialize the papilla. My favorite tool is the microsurgical scissors, just cut it and remove the epithelium. So there are various types of lateral harvesting technique. The common one is a trapdoor and a single incision. For this case, I did double incision because I want the small band of epithelium. This is how I adapt my graft. CTG with the epithelium collar. And the epithelium collar is meant to expose. And for this case, I issue palatal coverage spleen to improve comfort. Okay, because patients stay 1 hour away from my clinic, and she was a bit anxious. So for comfort, yeah, this to cover the wound, and patient can feel comfortable with that without the wound exposed. Okay, it took about 4 weeks to heal. So this is the recipient site, root coverage, complete root coverage achieved. So this is before and after 18 months. Right? So yeah, for aesthetic region we go for CTG. For mandible, I always go for free GR graft. Okay, now come to an old age patient who also came for dental implant, complaint of receding gums, and wish to replace close the space between the 2 premolar on the lower left. So, and my main objective is just to improve the 1.3 and 1.2, and because of the patient is almost 70, so I didn't extend the flap too long, just up to the 1.2. And what I expected is partial root coverage because it was RT2. This is how I prepare my flap, deepithelialized with the micro scissor. So this is the free deepithelialized free GR graft. I harvest the free GR graft and then I remove the epithelium. So this is a pre and post, 7 months. Okay, the same patient, she did GBR before I continue the case. So at that time, I saw when I want to continue implant treatment, there's no frenum and there's almost shallow to absence of vestibule. What I did is I did soft tissue grafting first to reposition the frenum back to the original position by using GR graft. Okay. So this is the donor site by 3 weeks in a healing process. So it's after GBR, 3 weeks, 3 months, 17 months after I issue the crown. So just to show the dimensional changes of the soft tissue and hard tissue, having this keratinized tissue around the implant, it acts as a barrier to protect the implant from peri-implant disease. Okay, now we move on to the last part, around dental implants. Soft tissue phenotype modification around implant aimed at modifying the peri-implant soft tissue phenotype to increase the keratinase, the thickness, and the soft tissue height, not only for aesthetic but also for health-related parameters, the plaque index, GI index, and bone loss. So this is a show before and after free GR graft on the mandible. Okay, having this FGG, this keratinase and increased tissue thickness, improve the quality of tissue. It promotes peri-implant health by improving the patient comfort and hygiene procedure. You think this is what this area without the attached tissue, patient can clean? No, because of the movable tissue. But having this keratinized attached, patient can clean better. So better oral hygiene. And this can prevent and also treat the peri-implant disease. So for implant, surgical technique either apically position the flap or bilaminar, 2 layers, meaning the graft below the flap. So you can use autogenous or soft tissue. If patient afraid of surgery to harvest, go for soft tissue. But as you know, based on the evidence is they are more effective in increase the thickness. It's still the autogenous better than substitute. So this is to show the process of the surgery where how they suture the FGG and apically position the flap. And this is a bilaminar technique. They also harvest the free graft, remove the epithelium, become the de-epithelialized free graft, and then they coronally advance the flap to cover this area. They did the gingivoplasty because the tissue was bulky. Okay. Evidence. Review all the evidence. There were 23 randomized control trials, 16 on bilaminar approach, only 7 on apical position flap. They found, and they also explore the impact of the phenotype changes in promoting peri-implant health. They found out that apical position flap and FGG is the most effective when you plan to increase the keratinized tissue. But if for bilaminar technique with CTG or collagen matrix, they find there's no difference if you use CTG or collagen matrix. Maybe it's because of lacking of articles on CTG and bilaminar and collagen matrix. They found similar result. They found that less marginal bone loss if you use either one. And if you use CTG or ADM, gain mucosa thickness than the collagen matrix. But because they are lacking of evidence, they need more study to explore further on this factor. So if you want to plan for increase the keratinase, go for apical position in non-aesthetic region. Yeah. So another 3 more cases I would like to share. 2 from my friends. This lady, 68 years old female, pain on brushing, and you can see one implant is presented peri-implant soft tissue adhesion (PSTD). Because I don't have the occlusal view, I cannot differentiate which is the class 1 to 4. So this is how she did, and she covered with I think it's called colapla, and yeah, the objective was just to thicken the tissue. Yeah, so she did bilaminar technique with de-epithelialized CTG graft on labia 1-1. So after the healing, you find the tissue is thick, and yeah, because you find the crown margin is actually still not similar, because the aim was just to improve the quality of the tissue, not to cover overall, because could be the crown could be out of the compared to the ideal if it is a class 3, so you could never achieve ideal mucosa margin. Okay, so for this case, it's more to augment, to modify the soft to thin to thick phenotype. Okay, so another case, patient presented with redness around the implant. On upper left implant, there are 2 implants. One is semi-retained, one is screw-retained. As you can see, 2, 3 here, the tract is exposed and lacking of keratinized attached tissue. And Dr. Lau back then was she performed bilaminar technique with CTG just to treat on the 3 implant. And then because tissue of peri-implant tissue is very sensitive, and if you try to tense the flap and try to close, eventually you may lose tissue more. So that's why her primary objective is just to thicken the mucosa. Okay, so this is the result after 6 months. And because of the crimping attachment, then you gain more tissue over the time. Okay. My last case, patient had 1.4 and 1.5 implant, complained of receding gums over the years since 2020. Patient on anti-inflammatory drugs to manage the ulcerative colitis. She had 2 times of COVID. When I want to start to do surgery, she had COVID and quarantine. And that's why it was delayed for 2 years back then. And then patient had the implant more than 20 years ago, and she did lateral sinus lifting. To show the implant site, you can see this area, there's some residual bone graft underneath the mucosa. And no opposing tooth. And patient, I asked the patient why there's no opposing tooth, and she couldn't recall when she lost the tooth or she didn't restore it. So this is to show the soft tissue changes when patient started to clean effectively, and you can see there's a apical shift on the mucosa margin. So this is when before I started my surgery. So before I start, I try to find what implant system is that. Look for what implant is that.com. And I've come to realize it could be Dentsply, Freudenfrelly implant. And in Malaysia, no more. There's no supplier selling this. But how about Vietnam? I'm not sure. Yeah, because sometimes we may need to look for the prosthetic part, convert into healing abutment to gain more soft tissue, right? So, and the parallel charting shows that there is deep pocket depth around 1.5 on the palatal. So initially, I tried to explore whether I should keep the 1.5 implant. First, when I opened up, I found a lot of loose bony residual bone graft. Even after 20 years, it's still there. So after I cleaned up, I found it's not. Patient agreed to remove it. I explained it with just a faucet, dental faucet. And for 1.4, I cleaned with titanium brush and also decontamination with photodynamic therapy. So before that, I also harvested CTG through trapdoor technique, just to compensate if there's any soft tissue loss after the surgery. And that the implant site that expanded, I also packed some bone graft, just in case patient plan to do implant later on. Okay, this is what I harvested for the CTG. Okay, this is 6 months, same thing, sorry, I only have 6 months follow-up because I just moved to a new clinic. And just to show the baseline at 6 months. Hopefully the soft tissue margin stay over the time. Well, key points. So before I end my presentation, I want to share some key points. So look beyond the recession. Always assess what the adhesion loss, the phenotype, whether it's thin or thick, the vestibular tap, whether it's shallow or deep, whether there's frenum pool, or whether there's cervical lesion. Okay? Always go with your comfort level in the surgical technique. Just go as, like me, I started off the FGG practice first. And FGG also good because it can convert to deepitalized FGG, right? So expectations is set straight before the therapy of what you can achieve. Discuss with the patient what you can achieve. Whether you want to achieve root coverage or you just want to thicken the tissue, right? And preservation and maintenance of keratinized tissue at least 2 mm for periodontal and periimplantal. Soft tissue phenotype modification through this soft tissue augmentation is beneficial when patient has poor blood control and requiring additional treatment. Additional treatment such as implant therapy, orthodontic treatment, restoration with intracircular margin. And also beneficial in improving patient comfort and efficacy of oral hygiene procedure by reducing, by facilitating the blood control. Having a good tissue, patient can clean better. So these can eventually promote periimplantal, prevent and treat the periimplant disease. However, when patient has good blood control, very good, so it's not minimal amount keratinized tissue is not needed to prevent attachment loss. If patient has a good blood control, disease only happens when patient has poor blood control. So this keratinized tissue is act as a protective layer. Okay, good. Before I end my presentation, I would like to share a quote: do the best you can until you know better, and then when you know better, do better. I'm still improving my surgical skill. I'm trying to practice more by doing more soft tissue grafting. So I hope after my presentation, I hope those who have not started any soft tissue grafting can start to do some free grafting on the non-aesthetic side, mandible. Yeah. So thank you for your attention.